Okay, so the adrenal glands. Okay, the adrenal glands are small bilateral structures that lie retroperitoneally at the apex or the top of the kidney. Aldosterone is a principal mineral corticoid that we're going to talk about. Cortisol is the primary glucocorticoid, and androgens are the primary main sex hormones. So these are some of the things that we're going to get into as we discuss where these hormones go. First, you have to understand the adrenal glands and the medulla versus the cortex, and what's the difference in the two. The medulla of the adrenal glands secretes epinephrine and norepinephrine, which is part of our sympathetic nervous system, our fight or flight response. The cortex forms up the bulk of the gland. It's responsible for secreting those hormones that I told you about, and these are called glucocorticoids, which is our sugar hormones, mineral corticoids, which is our salt hormones, and androgens, which is our sex hormones. That's why you think of it, adrenal glands as the three S's, the sugar, salt, and sex hormones. So the sugar, glucocorticoid, we're going to talk specifically about cortisol. The salt hormone is the mineral. So salt is a mineral, think of it that way. Mineral corticoids, and that is aldosterone that we're going to focus on. And then our sex hormones are our androgens, okay? So basically the medulla, if the medulla fails, which is the epinephrine, norepinephrine kind of thing, a fight or flight response, it's not essential for life, for us to live. However, the cortex, if the cortex fails and goes untreated, okay, for a small period of time, it is completely fatal and you will die. So that's important to understand. You have to catch these things in a timely manner. So the secretion of the glucocorticoids and the androgen is actually controlled by the ACTH, or the adrenocorticotropic hormone, which comes from the pituitary gland, the anterior pituitary. So once again, when we think about primary, secondary, tertiary, a primary adrenal gland problem will be a problem that is actually occurring in the adrenal gland itself. A problem in the pituitary gland would cause a secondary adrenal gland issue. So the sex hormones, and why do we need them? Basically, your sex hormones are your androgens. I already told you that. And you need them because they're important for like pubertal development, growth of body hair in women, enlargement like the testes. It kind of helps with that as well. But basically, you need your sex hormones, for normal functioning, just everyday functioning of those reproductive systems. But if you didn't have those hormones, you could supplement those with medications. The mineralocorticoids, how are they used in the body? How are they regulated? And what happens if you have too much? Let's talk about that. So basically, mineralocorticoids regulate our potassium and sodium levels and our water balance. Okay. Aldosterone secretion is regulated by the renin-angiotensin mechanism. So in that system, we kind of talked about that in the renal system. You have the angiotensinogen and all that is produced with when blood pressure is signaling that it's low. And basically what happens is the adrenal glands also, once that process begins and it senses a low blood volume or a low blood pressure, aldosterone is secreted from the adrenal glands. And it works by regulating the levels of potassium and sodium and things of that nature. So we see increased aldosterone secretion causes us to retain sodium in the distal tubules of the kidney. So the kidneys will soak up the sodium. We know that water follows sodium. So by soaking up and retaining sodium, we retain more fluid, which will increase our volume and bring up our pressure. But at the same time, when this occurs, we also increase our urinary losses of potassium. So if we're in overdrive and we're secreting too much aldosterone, then we're losing too much potassium because the body is getting rid of it. So we have to worry about hypokalemic issues. In the glucocorticoids, cortisol is synthesized in the cortex of the adrenal gland and regulated by the negative feedback mechanism. Again, going back to the air conditioner, supposed to cut off and cut on based on the feedback. It's regulated by the negative feedback mechanism, of the hypothalamic pituitary adrenal system, which is the HPA system. The hypothalamus secretes, let me make sure I'm telling you the right word. I say it wrong. So the hypothalamus secretes the SRH hormone, corticotropin releasing hormone, which controls the release of ACTH. The ACTH releases the cortisol, and then levels of cortisol increase as the ACTH increase. So what we'll see is the levels of cortisol rise with the levels of ACTH, and the levels of cortisol will fall as the levels of ACTH decrease. The pattern we see is usually what we call in sync with the circadian rhythm or the wake-sleep cycle, so that cortisol levels will be higher in the morning time, around 6 to 8, and significantly less in the evening time. The reason for that is when our cortisol levels, when they increase, it makes us wake up, we get more alert, things like that. We're ready to go for the day, and then they significantly will wind down in the evening time when it's time for us to go to sleep. So one of the earliest signs of a disorder that we're going to talk about, known as Cushing's syndrome, is loss of that diurnal variation in the CRH and the ACTH. So Cushing's, we'll see that loss of diurnal variation, where there won't be a response to the time of day, basically. Glucocorticoids respond to stress, and they're essential for our survival. They control the inflammatory process in our body. They stimulate glucose production by the liver. A process that we'll talk about is gluconeogenesis. They stimulate that to occur. The body proteins are broken down into amino acids, and they're transported to the liver, where in the liver they are used to produce glucose, and they cause mobilization of fatty acids from the fat tissue. Lastly, the cortisol that we secrete suppresses the immune response by decreasing capillary permeability and also stabilizing the lysomal membranes so that inflammatory mediators are not released into the system. So cortisol impairs inflammation, decreases inflammation. One of the things we're going to talk about when you talk about pharmacology and the drugs that we give, you are probably familiar with prednisone. Prednisone is a steroid that we're going to give somebody to decrease inflammation. And so this kind of works in the same way if you think about it that way. Cortisol suppresses the immune response by reducing humoral and cell-mediated immunity. So let's talk about the adrenal glands a little bit more. So adrenal glands, what do they do to sodium absorption? That's good. They increase sodium resorption by aldosterone. The potassium is excreted in the kidneys. Adrenal glands regulate blood glucose. They have an anti-inflammatory action. They affect our growth, and they decrease the effects of stress on the body. Okay, so they decrease the effects of stress on the body. So some of the tests that you need to be aware of is our serum cortisol levels, aldosterone levels, ACTH, using the immunoassay methods, 24-hour urines for free cortisol. We'll talk about late night serum or a salivary cortisol level, and we'll talk about something called a dexamethasone suppression test. These are all excellent screening tools. And that information you can look up a little bit more on 786 in your textbook. The adrenocorticosinsufficiency, which is hypofunction of the adrenal cortex. Basically, I told you primary and secondary causes. Primary would be a destruction of the adrenal gland itself, and the disease we're going to talk about is Addison's disease. When it's a secondary cause, that means that there's a disorder from the HPA system, and so there's a lack of adrenocorticotropic hormone, or ACTH. So there would be like low ACTH levels. In a primary disorder, the ACTH levels would be okay. So we're going to talk and focus on Addison's disease, which is a primary disorder of the adrenal cortex. Okay. Glucocorticoids, mineralocorticoids, and androgens. Basically, when we see Addison's disease, we need to understand that all layers of the cortex are being destroyed, and so all the hormone levels will be low. But the ACTH level will still be elevated because the pituitary gland is not affected. The most common cause is an autoimmune response, and so you've seen that consistent through the thyroid and through the adrenal glands. It's usually autoimmune. The key thing is that manifestations typically don't even occur until we have 90% of our cortex destroyed. So our body kind of can make do with quite a bit of the cortex gone before we start to see any problems. And typically, the manifestations that you're going to see are related to the primarily to the mineralocorticoid deficiency, glucocorticoid deficiency, and hyperpigmentation that results from elevated ACTH levels. So this patient, when we talk about manifestations, this patient will actually have what we call a bronzed pigmentation of the skin, and that is due to elevated ACTH levels. Basically, we'll see like in this situation, it's a chronic metabolic disorder that requires lifetime hormone replacement therapy. We'll see increased losses of urinary sodium, chloride, water, a decreased excretion of potassium. So in this situation, we will see actually a hyperkalemic patient with a hyponatremia. Okay, so we have low aldosterone, which we talked about what the normal function of aldosterone was to retain sodium and retain fluids. But if I don't have enough of that in my system, then I'm not going to do those things. And so in this situation, you see the sodium being lost and the potassium being held onto. And we also will see with the sodium being lost, the fluids are being lost as well. So dehydration is very common. The patient will have something called orthostatic hypotension, whereas when their blood pressure might be normal or low normal when they're sitting or lying, but when they change positions, so as from lying down to sitting up or sitting to standing, their blood pressure drops significantly. Okay, like greater than 20 points, and their heart rate might also rise up. So this patient is very weak, they're very fatigued, they don't tolerate stress very well because they don't have those glucocorticoids to help with the stress. I told you about their skin already. Cardiovascular collapse and shock are major life-threatening complications that you'll see in this one. And a crisis in this situation, adrenal crisis, would be kind of everything heightened as well. So severely elevated potassium, severely low sodium levels. The kidneys begin to shut down. The patient is really profoundly dehydrated and lots of fatigue. So like you'll see hypotension occur again. So it's a bad, if there's a crisis situation, the patient could die if we don't respond appropriately to them. Their gums and their oral mucous membranes also will become bluish black. And again, that's from that ACTH elevation. So let's look at Cushing's syndrome. When we talk about hyperfunction of that adrenal gland, what we see mostly is the hypercortisolism. So again, too much of the glucocorticoid, which is cortisol, too much aldosterone, and so we're going to focus that. So you might see this because of a pituitary problem where there's too much production of ACTH, or about, from like a tumor that's secreting that. So what do I have here? It's hyperfunction of the adrenal cortex, common abnormalities caused by excess glucocorticoids, specifically hypercortisolism. A cause could be excess production of ACTH, adrenal tumors, non-pituitary secreting tumor, a tumor that's not dealing with the pituitary gland that is secreting this ACTH is a cause as well. And with this one, it's kind of the opposite of what you just saw. This person will actually have elevated blood glucose levels. They'll be retaining the sodium and retaining fluid, so they're kind of puffy. They have some extra fluid. They have what we call protruding abdomen. fat pad on the subclavian area is known as a buffalo hump. They have altered fat metabolism. They have a round moon face. This is classic of somebody with too much steroids on board. We see the appearance of thin extremities with a large truncal obesity kind of thing going on. You have striae that's evident, which you see on those little legs down here. You can also see the striae on the lower abdomen. That's another place that you can see that. Osteoporosis may develop because of destruction of bone proteins and alterations in calcium metabolism. So osteoporosis is a big deal with these patients. And you see the guy has a broken leg because of that. You see the males with the gynecomastia, which is like increased breast tissue. And so these things are things that you would typically see. Hirsutism is abnormal hair growth. Your book at some point says it's a male pattern hair loss. That is not correct. It is inappropriate or abnormal facial hair growth. There's a picture on page 789 that kind of shows you a lady with abnormal hair growth like under her chin and where the mustache would be. And that's hirsutism. I can't say it. But these patients would be increased susceptible to infections. So those are some of the signs that you would see there. And lastly, when we talk about diagnosis of these two, basically, when we talk about Addison's disease, you would see like low cortisol levels, low aldosterone levels, but elevated ACTH levels because Addison's is a primary disorder of the adrenal cortex. Cushing's disease, you have a 24-hour urine that we would do for free cortisol levels, provides a reliable and practical index of cortisol secretions. One of the prominent features of Cushing's is loss of the diurnal pattern of cortisol secretion. So again, remember we talked about they won't have that, they lose the ability to secrete more in the morning and less at night. And they'll do a dexamethasone suppression test, which you can read up on, but basically that's used as a screening test. We might see ACTH levels as normal or elevated in Cushing's. So that will conclude the diagnosis of the adrenal system.